Omar. My name's Ben. Do you mind if I examine you?
No.
With the patient adequately exposed, look for asymmetry. Inspect both proximally and distally. Note any deformities such as clawing of the hands. Look for muscle wasting or hypertrophy, fasciculation or involuntary movements. Fasciculations are often elicited by flicking the skin over a muscle.
Just let your arms go floppy for me.
To test tone in the upper limb, hold the patient's hand as if shaking it. Use your other hand to support their elbow. Rotate the forearm, flex and extend the wrist, elbow and shoulder, varying the speed and direction of movement. Muscle tone is the resistance felt by the examiner when moving a joint passively.
Again, let this arm go floppy.
Always compare sides. Muscle tone can be pathologically decreased or increased. There are two principal types of hypertonia: spasticity and rigidity. Next, examine the deep tendon reflexes. The biceps jerk mainly incorporates the C5 nerve root.
And relax.
Use your finger or thumb to palpate the biceps tendon. To test the supinator or brachioradialis jerk, the forearm is in the mid-prone position and you strike the tendon overlying the distal end of the radius. Move the patient's arms to allow a good approach to the triceps tendon. This reflex involves C6 and C7. Eliciting reflexes and deciding if they are normal requires practice. Use reinforcement whenever a reflex appears to be absent.
I'm going to strike your arm again. When I tell you to, clench your teeth, but not before I tell you to. Clench.
For the upper limb, ask the patient to clench their teeth or make a fist with the other hand.
Relax the hand.
For the finger jerks, place your middle and index fingers across the palmar aspect of the patient's proximal phalanges. Tap your own fingers with the hammer.
Relax.
And look for flexion of the patient's fingers. To test the Hoffman's reflex, place your right index finger under the distal interphalangeal joint of the patient's middle finger. Using your right thumb, flex their distal phalanx downwards and look for the pathological flexion response in their thumb.
Can you hold your arms up by your side like that for me, please? Stop me from pushing them down.
Power in abduction.
Stop me from pushing them up.
And adduction.
Now hold them out in front of you like that. Stop me from pulling them away.
Elbow flexion.
Stop me from pushing them in.
And extension.
Now place your arms out in front of you and spread your fingers. Stop me from pulling your fingers together.
Abduction of the fingers by the dorsal interossei and adductor digiti minimi.
Now I want you to grip my fingers and prevent me from pulling them away.
Use your index and middle fingers inserted from the thumb side to test grip strength.
And relax.
Now test coordination.
Now can you place your arms out in front of you, please? And hold them in the same position.
To elicit rebound, push the patient's wrist quickly downwards and watch the returning movement.
And relax.
The finger-nose test.
Now take the index finger of your right hand and place it on your nose. Touch my index finger on your nose and do that rapidly for me, please. I'm now going to start moving my finger. I want you to follow it. Now do the same with your left hand.
Start slowly with the explanation before asking the patient to speed up.
I'm now going to start moving it.
If they perform well, then begin to move your finger. Look for past pointing or intention tremor that would indicate cerebellar disease.
And relax.
Test the ability to make rapid alternating movements.
I want you to alternate with your right hand front and back like that.
Impairment of rapid movements like this is dysdiadochokinesis.
Stop. Now do the same with your left hand.
Evident as slowness, disorganization and irregularity of movement, also a feature of cerebellar disease.
Relax. Now I'd like you to pretend you're drinking a cup of tea on a saucer.
Apraxia is difficulty performing a motor task despite the patient understanding it and in the absence of motor weakness, cerebellar, extrapyramidal or sensory impairment.
Now I'd like you to copy those shapes and then write a sentence.
Inability to draw a geometric figure is called constructional apraxia and is a feature of parietal lobe disturbance. Writing a sentence requires intact language function as well as fine motor control of the hand. Dysgraphia is normally due to a dominant parietal lobe lesion.
Now could you put on your jumper?
Dressing apraxia is often associated with spatial disorientation and neglect. It is usually due to a non-dominant hemisphere parietal lesion.
And relax. Thank you. Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
Expose the lower limbs as much as possible with regard to the patient's comfort and dignity. Look for asymmetry or deformities proximally and distally. Examine for wasting, hypertrophy, fasciculation and involuntary movements. Sometimes fasciculation is elicited by flicking the skin over a wasted muscle.
Just want you to let your legs go floppy.
Examine the tone in the lower limb, first by rolling or rotating it from side to side, then by briskly lifting the knee to a flexed position. Tone can be increased or decreased, and there are various patterns of increased tone, such as spasticity and rigidity.
Just relax again.
Test for clonus at the knee joint with the patient relaxed and the knee extended. With your thumb and forefinger, sharply push the patella towards the foot. Clonus is a rhythmic series of contractions evoked by a sudden stretch of the muscle. A few beats of clonus is normal in healthy individuals. To elicit ankle clonus, support the patient's leg with both knee and ankle at 90 degrees. Briskly dorsiflex and evert the foot, sustaining the pressure. Next, we test the deep tendon reflexes.
Just let the leg go floppy over my arm.
The patient should be relaxed and comfortable. Anxiety or pain can increase the response. For this reason, we test the reflexes after tone but before power in the examination sequence. The knee jerk tests the L3 and L4 nerve roots. Compare both sides.
This time I want you to clasp your hands together. Grip when I say grip, but not before.
Use reinforcement if a reflex appears to be absent.
Grip.
When testing the lower limb reflexes, ask the patient to interlock the fingers and pull one hand against the other.
Grip.
This is the Gendrasik maneuver. The patient should relax between repeated attempts. Now, we test the ankle jerk reflexes. They use the S1 nerve root. This is a method to use with a recumbent patient. Next, the plantar response, a superficial reflex. Run a blunt object along the lateral border of the sole of the foot towards the little toe.
Just going to run this stick up the sole of your foot.
The normal response is flexion of the great toe and of the other toes. Next, systematically test power in the muscle groups of the lower limb.
Now lift your right leg straight up off the bed.
This shows the ability of hip flexors and knee extensors to overcome gravity.
And the same with the left leg.
Use the MRC scale from 0 to 5 to grade power. Test the same groups in isometric contraction against resistance.
And relax. And the same on the left side. Push up.
The hip flexors
and relax.
And the knee extensors.
Now keep your legs straight as I try to bend it.
Always compare sides. Remember that strength can vary greatly with age and occupation.
And the same on the left side. Try to keep it straight. Now bend the leg up. And try to pull your heel towards your bottom as hard as you can.
This is testing power in the knee flexors.
Relax.
Make sure that, whenever possible, you use the same hand, posture and mechanical advantage to apply the force in order to make valid comparison.
Now point your toes up towards the ceiling and hold them there as I try to push them down.
Testing the ankle dorsiflexors and toe
The
extensors.
same on the left side. And don't let me push them towards you.
Plantar flexion at the ankle and toe flexion. Take care that you don't hurt the patient by inadvertently leaning on them or squeezing them with your other hand.
Now I want you to run your heel down your shin like this.
This is a test of muscular coordination called the heel-shin test. It is abnormal if the heel wavers away from the line of the shin due to cerebellar ataxia. Lastly, the abdominal reflexes.
Just pull your vest up for me, please. Just going to run a stick across your tummy.
Use an orange stick and stroke briskly but lightly in a medial direction across each quadrant of the abdomen. The normal response is contraction of underlying muscle with movement of the umbilicus.